Welcome to The Explainer. Today we're tackling something every single general practitioner sees all the time, but it absolutely requires sharp algorithmic thinking. We're talking about the clinical contraception algorithm. Consider this your vital, quick reference guide for prescribing contraceptives safely and effectively in a clinical setting. I am thrilled to break this down with you, so let's get right to it.
Picture this. You're sitting in the clinic and a patient sits across from you asking for birth control. Sounds super simple, right? Well, not exactly. As a clinician, how do you safely and effectively make the absolute perfect choice for her unique physiology and medical history? It's literally never a one-size-fits-all scenario. You've got a ton of options, sure, but you're also navigating a total minefield of contraindications.
Okay, let's dive into this clinical decision tree we'll be walking through today to ensure safe prescribing. First up, the consultation. Then we'll compare COCs versus POPs, look at safety during lactation, cover IUD selection basics, and finally, those critical contraindications.
Section 1. The Contraception Consultation.
Before we prescribe absolutely anything, the first step, without exception, is always a pregnancy test. We have to rule out an existing pregnancy, period. Once that's clear, we move to step 2, digging into the patient history. You really need to check her parity. Has she had kids before? And her current lactation status. Only after grabbing those vital details can you move to step 3 and actually match the method to her profile.
Section 2. Cox versus POPs.
So, let's break down the binary divide between the two main types of daily pills based on their biochemical makeup. On one side, we've got combined oral contraceptives, or COCs, which pack a combo of estrogen and progesterone. On the other side are progesterone-only pills, or POPs, which, as the name gives away, completely exclude estrogen. That single hormonal difference is a huge deal. It totally changes how and when you prescribe these. And this brilliantly illustrates how that hormonal difference drastically impacts a patient's daily routine. With the COC regimen, she starts on day 1 of her cycle, takes the pill for 21 days, and then stops for 7 days for a withdrawal bleed. But the POP regimen? A totally different story. She starts on day 1 and just takes it continuously, 0 breaks. Because of that constant hit of progesterone, it often suppresses menstruation entirely.
Section 3. Safety during lactation.
In the clinic, you'll hear POPs, commonly called lactation pills. Why is that? Well, they are the absolute gold standard for nursing mothers. Think about it. If a new mom was taking COCs before her pregnancy, she can't just jump back on them while breastfeeding. That estrogen will interfere with her prolactin access and tank her milk supply. POPs dodge that issue completely. POPs are heavily favored here for a few amazing reasons. They are perfectly safe for nursing moms, they do not mess with milk production at all, and because they're taken continuously, they typically halt menstruation entirely while in use, which is obviously super convenient for a new mother. The only catch? They require really strict daily adherence to actually work effectively. But wait, there's a massive clinical caveat you've got to keep in mind here. Progesterone actually restricts the motility or movement of the ovum inside the fallopian tubes. Basically, the egg moves slower. So if fertilization does manage to happen, there's a much higher risk it implants right there in the tube. Because of that, if your patient has any history of an ectopic pregnancy, POPs are strictly contraindicated, no exceptions. Section 4. IUD Selection Basics. When we shift gears to long-acting reversible contraceptives like the IUD, the physical prerequisites become super important. The ideal candidates here are multiparous women, meaning those who have given birth before. For nulliparous women who haven't had kids, the cervix is just much tighter and the uterus is smaller. It's not impossible, but those anatomical changes after childbirth make the IUD a much better, less painful fit. Otherwise, COCs are usually a better starting point. Now, what's really interesting about this contrast is the vital difference between the two main types of IUDs. You've got the standard copper IUD, which is purely a preventative method, but then look at the hormonal IUD. It isn't just for preventing pregnancy, it actually doubles as a fantastic therapeutic option for patients suffering from heavy menstrual bleeding. Of course, an IUD isn't a silver bullet for everyone. There are clinical scenarios where you generally avoid prescribing it or need to pull it out immediately. For instance, if a patient has recurrent pelvic inflammatory disease, or PID, the device can literally act as a dangerous source of infection. You also avoid it with unexplained excessive bleeding, unless you're specifically using the hormonal type to treat it. And, just like we saw with POPs, it's an absolute no-go if she has a history of ectopic pregnancy. Section 5. Critical Contraindications.
So the crucial point is this mental safety matrix right here. You really want to memorize this before your next shift. Let's break it down. For COCs, your absolute contraindications include a history of DVT, breast or uterine cancers, liver disease, heart problems, and diabetes. For IUDs, you're watching out for active PID or unexplained bleeding. And for POPs, like we said, a history of ectopic pregnancy is your major red flag.
And we absolutely can't stress this enough. If you have a patient actively taking COCs, you have to educate them on these immediate warning signs. If they suddenly get severe chest pain, severe calf pain, or a crazy, uncharacteristic headache, they need to stop the pill immediately. Those are textbook indicators of a potential deep vein thrombosis or an embolism. It is a life-threatening complication, and they need immediate medical attention.
To wrap up this explainer, I want to leave you with this thought. The best contraceptive out there isn't the newest one on the market or the quickest one to prescribe. It's the one that perfectly fits the patient's unique medical history, anatomical reality, and lifestyle. By systematically ruling out pregnancies, checking those contraindications, and really understanding the biochemistry, you make sure your choice is both highly effective and incredibly safe. But here's a question for you. With new hormonal formulations hitting the market every single year, are you updating your mental algorithms fast enough to offer your patients the true cutting edge of care? Something to think about. Thanks for learning with me today, and I'll see you in the next explainer.